This is a 58 years old woman with a history of class 3 obesity with a BMI more than 50. Despite multiple failed attempts with a diet as well as bariatric surgery post-sleeve gastrectomy, patient was referred for abdominoplasty and hernia repair. Her past medical history including hypertension, hypercholesteremia, psoriasis, as well as the laparoscopic sleeve gastrectomy. The patient was assessed. On physical examination, there was a palpable paraumbilical hernia was present. Preoperative CT scan was done and showed there's a mesogastrium lesion concerning for neoplasm, as well as there was an enlarged uterus and right iliac fossa mass were also noted on the imaging. So the problem list for this patient is known to have large midline ventral hernia with dermatochalasis post-bariatric surgery, paraumbilical hernia detected in physical examination. The third was hypodense mesogastric lesion detected on CT scan, as well as enlarged uterus with the right iliac fossa mass. Lastly, she's known to have multiple comorbidities including hypercholesteremia, hypertension, and psoriasis. How would you face the case? Option A, primary facial closure with anterior plication. Option B, staged abdominal wall reconstruction with a tissue expander. The correct answer is A, primary facial closure with anterior sheath plication.
Hello and welcome to PRS Global Opens Face the Case. I'm Dr. Oscar Fernandez-Diaz, and it's an honor to be here today to discuss a fascinating and unique case involving an ovarian leiomyosarcoma discovered incidentally during a postbariatric abdominoplasty procedure. In this case, the optimal immediate reconstructive approach following en bloc resection of the abdominal mass was primary facial closure with anterior sheath plication. This approach was chosen based on the patient's existing hernia and the need to ensure a strong and secure closure after mass removal, particularly given the prior bariatric surgery and weakened abdominal wall. In my opinion, the decision to opt for primary facial closure with anterior sheath plication was absolutely appropriate for this patient, given the complexity of her medical history, including class 3 obesity, previous bariatric surgery, and her multiple comorbidities such as hypertension and hypercholesterolemia. It was critical to ensure a durable and stable abdominal closure. Had the hernia and tissue weakness been more significant or the patient's tissue quality been further compromised, a staged reconstruction with tissue expanders could have been a consideration. However, the author's approach balanced immediate needs and long-term outcomes as well. This case report from PRS Global Open highlights the challenges of managing incidental findings during elective surgeries, particularly in patients with a history of complex medical conditions like this. The authors meticulously detail how they approach the leiomyosarcoma resection and subsequent reconstruction, emphasizing both oncological safety and functional recovery. Their use of the keystone technique for wound closure along with primary facial repair shows the versatility of modern reconstructive options in the face of unexpected findings. It's a strong reminder of how plastic and reconstructive surgeons must remain flexible and collaborative when confronted with intraoperative surprises. For more innovative and intriguing case reports like this one, visit prsglobalopen.com. Thanks for watching, and we'll see you next time on PRS Global Opens Face the Case.